Hello, this is Michael Altos, and we're recording the second part of our lecture series on the renal system. Now we're going to get to the diuretics that you're more familiar with. We're going to start with the loop diuretics, and the best example of that is Lasix. The generic name is furosemide, and there are other related drugs like torsemide, which is Demodex, or bumetanide, which is Bumex. All of these drugs work in the same basic way, which is that they prevent reabsorption of salt, specifically sodium salt, in the thick ascending limb of Henle's loop. And that's not so important where in the nephron it occurs, but the main thing to understand is that we have a pump called the sodium-potassium ATPase. It pumps sodium and potassium and chloride out of the urine, and loop diuretics bind to this pump and prevent it from working, and now these ions get stuck in the urine and water gets stuck there with them. A lot of the sodium and chloride that's reabsorbed from the urine back into your body occurs at this site. So Lasix is a very effective diuretic because it's working at a place where a lot of sodium is normally absorbed out of the urine. When we block that pump, we leave a large load of salt in the urine, and large volumes of urine are generated. Lasix and other loop diuretics are really the first line management of acute congestive heart failure. Remember that heart failure is a diagnosis, it's a condition. People have heart failure when their heart isn't working as well as it used to. Congestive heart failure is really an acute change in somebody's condition. Congestive heart failure happens when your heart failure can't keep up with your fluid balance, and as a result you become congested, which means you have backup of fluid into your lungs, into your liver, into your extremities. And so when patients are having an exacerbation of their heart failure and they go into congestive heart failure, we can relieve this congestion, this pulmonary edema, the swelling, the fluid overload, the peripheral edema. We can relieve all these things with a diuretic to get fluid out of the system. You could probably guess most of the side effects. If we block the sodium-potassium pump, then we're going to have more sodium and potassium in the urine, and they're going to be excreted, and patients will become hyponatremic and hypokalemic. And as they lose water, they can become hypovolemic. Now I have to emphasize, you need to be careful with diuretics. Diuretics are not used to treat the condition of not making enough urine. There are lots of reasons that patients might not be making enough urine. But if in your assessment the patient is fluid overloaded, then it would be appropriate to give a diuretic. But if a patient is hypovolemic and they're not making any urine because they're hypovolemic, and you go and give them Lasix anyway, so now you've made a dangerous combination of hypovolemia and diuresis, which can actually injure the kidneys. It can lead to acute renal dysfunction. And as their entire intravascular volume gets low, they're not going to be perfusing anything. They could get ischemia in their brain, or in their heart, or in their liver, or their GI tract, or their kidneys. Some people say there's cross-sensitivity between Lasix and sulfa drugs. But I haven't seen in practice that people are usually very careful about this. But it's something that you should at least be aware of because it's listed in the textbooks and in the drug inserts. People also talk about ototoxicity with loop diuretics. Again, not something that I've seen as a routine consideration. A normal dose for a loop diuretic is anywhere between 0.1 and 1 milligrams per kilogram. In a patient who's never had Lasix, 5 to 10 milligrams is a good starting dose. A related drug to the loop diuretics are the Thiazide diuretics, most commonly hydrochlorothiazide, usually written HCTZ. And it has a very similar mechanism of action. It also blocks sodium and chloride reabsorption, just in a slightly different part of the renal tubule. And so we see a similar result as we did with the loop diuretics. Patients excrete very large amounts of sodium and potassium, as well as some of the negative ions like chloride and bicarbonate. This sodium gradient causes people to excrete large amounts of free water. They also excrete potassium. And this drug is often given as a combination. As we'll see in just a moment, hydrochlorothiazide is often paired with another drug. So when do we use hydrochlorothiazide? Not very often for acute exacerbations of CHF or pulmonary edema. Usually we see hydrochlorothiazide given on an outpatient basis, on a long-term basis, as treatment for hypertension or chronic volume overload. We see it a lot in patients who have pregnancy-associated edema. The initial effect of hydrochlorothiazide is probably because we decrease the extracellular volume. We pull water out of the extracellular tissues. It may be that over time, hydrochlorothiazide causes a little bit of peripheral vasodilation, which also decreases blood pressure. The side effects are going to be very similar to Lasix. We'll see hyponatremia, hypovolemia. We actually do see some hypokalemia as well, although I didn't write it on this line. And some orthostatic hypotension. So hypotension, again, associated with the hypovolemia. Again, a hypokalemic, hypochloremic metabolic alkalosis. There are other rarer side effects like pancreatitis, diarrhea, aplastic anemia, hyperglycemia. These are less common. But as you can see, in many ways, loop and thiazide diuretics are very similar. Take a moment to see if you have any questions, and then we'll move on to the next section. Now, we've seen that many diuretics cause people to lose a lot of potassium. And so it's helpful to create a class of diuretics that spare potassium. And we call these potassium-sparing diuretics. Some of the older drugs are amiloride or triamterene. Now, these drugs block different sodium channels to prevent sodium reabsorption, but they inhibit the secretion of potassium from the bloodstream into the renal tubules. And so less potassium is lost this way. And we especially see these drugs used together with a loop or a thiazide diuretic. One of the most common examples is hydrochlorothiazide and triamterene, often known as Maxide or Diazide. And so we have a nice synergistic effect as well as far as diuresis is concerned, but we attenuate the loss of potassium. And that's why we call these potassium-sparing diuretics. In fact, patients can become hyponatremic but hyperkalemic when they're maintained on drugs like triamterene. And that's why the combination drug is a really nice balance. Now here's a picture you may remember from a previous lecture. Here again we have our renin, angiotensin, aldosterone system. And in the past, we spoke about angiotensin converting enzymes and the inhibition of angiotensin converting enzyme being used as an ACE inhibitor to treat hypertension. We also talked about aldosterone being at the end of this pathway, and aldosterone has two primary functions: save sodium and p-potassium, and that's how I've always remembered it. And when you save sodium, the water follows the sodium, and the potassium often moves in the opposite direction of sodium, so they save sodium and p-potassium. Now we can antagonize the aldosterone receptor, and if we block that, then patients won't be able to save sodium and p-potassium. They will do the opposite. They will excrete the sodium and all the water that follows it, and they will save potassium. And so this is also a potassium-sparing diuretic. The most common example is spironolactone. As we said, it inhibits reabsorption of sodium. It causes potassium retention. And this drug is used a lot in patients who are volume overloaded due to heart failure or cirrhosis. Side effects, as you can guess, are hyponatremia and hyperkalemia. Gynecomastia is also seen, and that's because aldosterone is really a steroid hormone. And so we're getting involved more in the steroid aspect of our hormonal regulation. That's it for this section. If you have any questions, get in touch with me by email, or we can discuss them in class. See you guys later.